The next session is on the Achilles heel of pancreaticoenteric. I invite Dr. Ramesh Ardhanari sir for the presentation. The topic is difficult pancreaticoenteric anastomosis, perioperative strategies.
Thank the organizers for having invited me to give a talk on a difficult topic. Because as all of us know that in the Whipple's operation or the pancreaticoenterectomy, the Achilles heel of the operation is the pancreaticobiliary anastomosis. So let us see what to do if you are in trouble. It's one of the most difficult, the pancreas is of course a difficult organ to anastomose because it's usually soft, but if it's firm like in chronic pancreatitis, you never have the discussion of pancreatic leaks in a chronic pancreatitis. You have it in a Whipple's. Why? Because in chronic pancreatitis it's a fibrotic pancreas and that doesn't leak. There are very critical surrounding structures, and if you leak, especially if it's mixed with bile, it's an active pancreatic juice. If it's a pancreatic leak alone, it is not an active juice. Please remember the two distincts. If you have bile and pancreas, it is bad. If you have only pancreatic leak, it's not so bad. And when it leaks with the bile, then it starts to digest the organs around. Usually, somehow, the veins don't get digested, but the pulsating arteries get digested, and they form pseudoaneurysm and then they bleed. So, how can we prevent? There are some articles, this is about 2024, and it showed that all postoperative pancreatic fistula incidence was about 27% over 21 studies. The C grade of the fistulas was about 17%, which means that these are the bad leaks. Using somatostatin did not help, prophylactic antibiotics did not help, intraoperative drain use did not help, stent use did not help, you still had a high, and suture closure use, again, no help. So, nothing of these strategies actually help you to tackle it. So, what are the factors that tell you that this is a difficult pancreas and this is an easy pancreas? Now, when you have a soft pancreas to handle, and there have been studies, Claude Bassi, who is now no more, who was one of the people who did a lot of studies on pancreatic texture, he actually had made a machine to measure, like the fibroscan, it would measure the amount of fibrosis in the pancreas, and he would then, he showed a formula where he said that the more fibrosis there is, the less the chance of leak. But we don't have access to such machines, so we just tend to feel it. Very soft pancreas, usually a bad result. May have, not usually, may have a bad result. A hard pancreas, a firm pancreas. As I said, in chronic pancreatitis, you do a huge anastomosis. It never leaks. Whereas in a smaller anastomosis, in an ampullary, where the pancreas is normal, you do have higher leak rates. If the duct is very small, the leak rates are high. Patient's BMI is very important. A high BMI, high leak rates. So on imaging, if there's a normal pancreas, there's no fibrosis, no calcification, higher leak rates. So if you have a pancreatic head tumor, it automatically blocks not only the bile duct but also the pancreatic duct. So it results in some amount of dilatation of the duct and some amount of hardening of the pancreas. So it makes it that much safer. So head pancreas leaks less than ampullary tumors. If you have malnutrition, albumin less than 3.5, leak rates are higher. And of course, if you have chronic pancreatitis, that's the best patient to operate. So these are all the, as I've already said, the risk factors. Apart from soft texture, you also, if you intraop, you have a high blood loss. Then your chance of having a leak rate is higher, because obviously if you have taken a longer time, there have been some complications, patient has been given blood, and when you are given cold blood, you become acidotic, and then once you are acidotic, your anastomosis ends no longer have that good perfusion and oxygenation which they should have. Poor nutrition is an obvious thing. Male gender sometimes leaks more. Moises Jacobs, a very famous American surgeon, once said, the safest patient to operate is a woman with black hair. What he meant was that there's no grey hair. So that patients usually have no complications whatsoever. Apart from all this, of course, the surgeon's experience is very important, but somehow I don't believe in this. I have now done nearly over 1,000 frays, and I have done about nearly 1,000 Whipples over 35 years of practicing at Meenakshi Mission Hospital. Not only me, all my colleagues included. The frays never leak, but the leak rates of the pancreatic anastomosis remains the same even after so many cases. So I don't know whether experience really makes that much of a difference in the leak rate, though some people have said that it's an important factor. So this is a fistula wrist sore developed by Callery to predict post-operative pancreatic fistula. A score of more than 7, and you can all look at this in the books. I'm not going to read out. But the important thing is intraoperative blood loss is considered as an important factor, and also the factor whether it's ampullary or pancreatic adenocarcinoma, and the duct diameter is considered important. So what are the types of anastomosis that we have? We have the PJ, which also has 3 types or 4 types or more also, because each surgeon does his own. You have the classical ductal mucosa, then you have the dunking operation, and then you have the binding operation of Peng, then you have the PG, which is usually a dunking operation, and then in selected situations, I am going to introduce a new concept to you today, is exteriorization of the pancreatic duct. Don't do an anastomosis. I am going to talk about that a little more in detail in later things. So there are different types of operations I am not going to go and name. The Kelly-Blumgart anastomosis, which was famed in the biliary anastomosis, has been almost copied in the thing where you do a pancreatic duct to mucosa. So it is the small opening in the jejunum, and then you do a duct to mucosa with a fine 5-0 PDS or even a proline suture. Then there is the side anastomosis as described by the Heidelberg group. And then there's a Peng's binding. I have never done a single Peng's binding technique, so I don't know how to do it, but it sounds simple. You have this end of the bowel into which you pull the pancreas, and then you tie a suture tight around the end of the bowel over the pancreas, and he says it has a nil leak rate. Whenever somebody says they have a nil leak rate, I tend not to believe. It's really, somebody says that they have a Whipple with nil mortality rate, I just turn my head and walk off, because making a comment is useless, because he's not going to listen to anything. So you have multiple procedures. And when you look at the overall POPF, as you see, Peng has a 0% leak rate. I don't know. If that is so, why don't the others follow it? Why doesn't the world adopt it? Why doesn't everybody do a Peng's operation if it is a 0% leak rate? Because people have tried the Peng's operation in India and they have had leaks. I know surgeons who told me that they have tried this and they have had leaks. So I don't know whether to believe Peng or not to believe Peng, because there's a published article, so I have to put the figures up. But the others all have an average leak rate of about 20%, which consists both A, B and C, all categories. Amylase levels being sometimes not exactly. What I would look at it is whether they define it as a C grade or a B grade, and that you see varies from somewhere around 4 to 7%. So preoperative, we already said how to predict. Intraoperative depends on the texture of the gland, duct size and pathology, and postoperative is the first day, high drain amylase, higher chance of. So what are the ways to look for a difficult pancreatic anastomosis? You can use stents, you can reinforce the anastomosis with the falciform ligament or with the greater omentum. You can use somatostatin analogs, none of which are proved to be useful. So I have now come to the point where I have a strategy. And I'm going to tell you that strategy in the next 1 minute or so. You of course optimize the patient, you control diabetes and comorbidities, stop smoking, and you put a stent, and of course weight management with BMI. It's not possible to lower the BMI if he is very off this thing. So the point I want to tell you, which I think has not been discussed very often. Prior to 2008, every duct that had a leak would present with a massive bleed because of a small leak. You have IOPG, there's a small leak from one corner. It will erode into the splenic artery or the hepatic artery, massive hematemesis. We go and control the bleeding. We reinforce the anastomosis, we redid the anastomosis, we did all sorts of things. All the patients rebled and all of them died. In 2008, I changed the strategy. I started that if there was a leak, the moment there was a leak, we would go in, we'll undo the anastomosis, close the stomach or the jejunum if it's been done by one of the others who does a PJ, and put a feeding tube into the pancreatic duct. The feeding tube goes into a chest tube, which is also brought up to the pancreas, close to the duct. It is stitched with a 40 PDS, which will dissolve in 2 or 3 weeks, so it will at least hold for 2 or 3 weeks, and then come out, externalize the pancreatic duct. And since we started doing that, there were a 90% survival rates in our post-operative pancreatic clinics. Only 1-2 patients have died. All the others have survived over the years. And much to our surprise, they did not require a reoperation to reimplant the duct. Somehow the duct found a way inside, or it just atrophied off, or what. The patients are doing perfectly well. The drains fell out by themselves after 3 months, and the patients are no pseudocyst formed. I thought a pseudocyst will form and we will do an endoscopic cystogastroscopy. No pseudocyst formed. Probably they just drained somewhere internally, a fistula, and they were doing fine. Based on that experience, I started to analyze my patients on the table. Whenever we had a bad case, a case that had a high blood loss because we had to divide and reconstruct the portal vein, and therefore we had a little messier surgery, or when the pancreas was very soft or the sutures were cutting through, I started to do a primary exteriorization. No anastomosis. Put the tube into the duct, put the drain, and bring it out and come out. The same thing which I would do for the leak, I did it before it leaked. And after that, we have not had a leak. Because whatever would have leaked has now been already abandoned by not doing the anastomosis. And this is something you can keep in your idea. If you, especially for some surgeons who have been operating for 8 hours, 9 hours, you're tired, at the end of the day, instead of doing a difficult pancreatic anastomosis, you might as well just externalize it and come out. And most often you don't have to go back in, and there is no oncological problems with these patients also. Post-operative strategies, of course, you do all the thing. If you find the fistula, then you have to manage it in the same way. But what I want to introduce to you today was this new concept of not doing the anastomosis in a difficult case. Think about it. I'm not saying that you should take me at my word. Think about it. Read about it. But this is now considered the best way to salvage a fistula. Then why not, in a difficult pancreatic anastomosis, it be the best way to salvage the situation and not do the anastomosis at all. Thank you very much.